today I will be presenting a case of complication, sir. It's a guide-induced dissection, and it is a common, it is rare but preventable complication. So I'll be discussing how I approach and how I manage this case. What I could have done to prevent this complication. So this patient is a 68-year-old male, non-diabetic smoker. He is suffering from chronic stable angina for last 6 months, and now he has come to me with crescendo angina for past 3 days. He presented to me on 28th of this month only, sir. Recently only, January, 28th January. He had sudden onset chest pain while he was lifting a heavy cylinder, sir, 3 days back. So after that, when he came to me, he just had T-wave inversion, lead 3 and AVF on ECG. But history was quite classical, and echo, although there was nothing contributory on echo, there was no RWMA, but I straightway took him for angiogram, and he wanted to come after 2 days. So I scheduled it for 31st of January, sir. So this angio was revealed double vessel disease. LAD had proximal 90% tubular lesion, and RC had dominant, which was dominant, and distal RC and PLV had diffused two. Actually, there were two tandem lesions, 90 to 95%. Both were significant. So he opted for an angioplasty, sir, in the same setting. So only challenge, although the case was very simple to begin with, but it posed few challenges. So that led to this complication. First challenge was severe radial artery spasm. I had to struggle for initial 20 minutes. After doing angiogram, the guide was not going. So I managed with NTG twice. Diltiazem also was given. Midazolam also was given to calm and waited for quite some time. When the curve of the radial artery pressure improved, only then I started. And all the time I kept 035 guide wire in exchange length thermo inside only till the sinus. So and I waited for quite some time, 15-20 minutes, till the time curve improved, radial artery pressure curve. Only then I started my case, sir. So the second challenge was selecting the guide. Again, same challenge. Radial artery spasm can occur again while changing the guide. So I thought of using Ikari guide, but that is not available. That is not being supplied these days. So I had to choose ULT1. So this guide can be used for both right as well as left interventions. So this is an angiogram. As you can see, it's a simple lesion, type A lesion, around 90% hair in the proximal LAD. We can see both views, sir. Is clear, sir. Sir, RCA had two tandem lesions in the distal part, sir. Distal RCA as well as PLV. So talking about the guides, sir, we can use all kinds of sorts of guides like Judkins, Implas, Voda, Kidney. Ikari is one supplied by Thermo, but it is not currently available, sir. So I tried to get this guide, but it is not available. They are not supplying anymore. So I had to choose this ULT1 guide, sir. This is Merit Medical Guide, sir. So starting with the ULT1 guide, I crossed the lesion with the Sion-View wire, sir, and dilated with the 315 NC balloon straightway. And then stent was 3.523 stent, and regulating stent was deployed. And this was the result after post dilatation with the 412 NC balloon, sir. This was the left intervention. So now I had to switch to the, so this was the final result after removing the wire and keeping the same guide wire, sir, inside the guide. I rotated the guide with difficulty because it was a spasm was still there. And so I could hook the ostium, but it was entering deeply, sir. It was engaging quite deeply. So with care, I crossed the Sion-View wire, which I had already parked in the guide, sir. Same wire was used, which was used for left intervention. So again, we can see, sir, here also, the guide is going deep, sir. At times when he is breathing, so it is collapsing into the vessel, sir. So this challenge was there, but I proceeded with the intervention, sir. And it started with the dilatation with the 2.515 balloon, sir. And at both the places, sir, both PLV and this I did, sir, distal RCA. And then I further dilated with bigger balloons, sir, 2.7512, sir. You can see the flow has already, STEMI 2 flow is there, sir. It is decreased. Earlier it was TIMI 3. So then I thought of deploying a stent. So basically there was a balloon induced dissection here. So I started deploying. But what happened, sir? While taking the again this hardware that is longer stent, sir, that guide again got engaged and this caused dissection. And when I was injecting to check the position of the stent, we can see that this became a spiral dissection. This was limited till this branch, sir, RV branch. So it started from the ostium and it went up to the mid RCA till the RV branch. So quickly I deployed the stent, sir, positioned it perfectly and then deployed it, sir. And now my job was to fix the proximal and to mid RCA, sir, so, till the ostium. So I straightway took 3.5 into 33 millimeter drug-eluting stent from proximal to mid RCA, and I took it purposely beyond the RV branch so that dissected part is covered, sir, from distally. So this was the first stent was deployed. Then I had to fix till the ostium. So I used a 4 into 23 drug-eluting stent for the osteoprox RCA, sir. This is the result after deploying the second stent, sir, and the dissected part. Sir, after this post-dilatation was done with the stent balloon, 423 only, for overlap portion, as well as I did, sir, osteal flaring. Sir, this wire I had parked inside the, so that guide should not enter repeatedly again inside, sir, and should not damage the stent struts, which were there in the ostium, sir. So that's why I had parked this wire, sir, in the ostium. Second wire, sir. So after that, if we see still the disease is there, sir. Maybe some intramural hematoma has caused this type of picture, sir, because I had covered the distal dissected segment, sir, completely. So I again use another stent, 3.526 this time, resolute integrity, and covered this sir, part also. So this was the result after. Then I started post dilating, sir, with the distally with the 3.512 and till coming back to the 412, sir, balloon till the ostium, and osteal flaring was again done, sir. Thereafter, I did osteal OCT also, and to see whether stent are expanded adequately or not, sir, and ostium is covered or not. So this was the result, final result, sir, when I finished the case, sir. Sir, I wanted to show the OCT picture, sir. Coming from the distal to the proximal part, sir. Here also stent is there, sir, but dye could not be cleared, sir, completely. I was injecting very carefully, sir, because I didn't want to damage the stent from the ostium by depooking again, sir, after removing the wire. So there we can see stents are still there, sir, and all are opposed, sir, well opposed. Expansion indication, sir, it is around 97%. If we take into account both the distal and proximal stent segments. Till the ostium, sir, is a well expanded stent. There are no malopposition, no edge dissections. Now we'll be coming to the guide. So this to summarize this post-PCI images, sir, from distal to proximal, we have achieved good minimum stent areas of 6.75 distally, 9.43, 9.47 in the mid, and 10.93 in the proximal RC, and near the ostium, sir, 11.97 and 11.93. So learning points from my case are, sir, proper guide selection with anatomical consideration of origin of the RC is very important, sir. And deep engagement of guide is preventable using the guide wire in sinus, which I realized late, and I used this guide wire in the sinus to prevent damaging the stents further. So another important thing is you should not lose patience and never should not lose wire, because patient will give for time, sir, to us to manage that complication. And guide-induced dissection should be managed with immediate stenting, sir. And intravascular imaging, if available, should be utilized, and it is helpful, even showing us the expansion of the stent, sir. So that's all about my case, sir.
Few things come to my mind which I'll like to discuss.
Sir.
Via radial,
Yes, sir.
The guides usually tend to dive deep into the coronaries. So that
Yes,
is one, we have to be extra careful while we are doing a PCI through radials, that guides should not dive down deep into the coronaries. And the best
okay,
way I figure out is, while we do that, we should actually try to reduce the coaxiality. So at the ostium, rather, to make it lesser coaxial with the vessel, you give an anti-clockwise rotation to the guide,
okay, sir.
so that it's not looking directly into the coronary mouth. It should be like this.
Okay, sir.
So make it non-coaxial. After you have wired, retrieve your guide at the ostium and give it anti-clockwise rotation so that it is not coaxial. And that way it has lesser tendency to dive down. But I am not taking away that this happens. Despite you do every maneuver, still it can happen, still it can dive down, still, and if there is a plaque artery, it can dissect. But that is the only way. And second way, you realized it later, you could have done it earlier, that you place one wire into that aortic sinus
Yes, sir.
initially and make a bigger loop. It was while you are placing your wire into the aortic sinus, you are there only with the softer part of that wire. So make it slightly more,
Okay, sir.
so that it has lesser tendency. And if the guide has a tendency, that wire should act as a resistance to that. But in the end, you managed it quite well. Do you have IVAs there?
Sir, I've got IVAs also, sir.
So in such situations where dissections happen, and you can have actually IVAs where you don't have to give more injections or more forceful injections, even after stenting, because there was some part which was non-stented, So, but otherwise, I think in the end, you manage it quite well. Quite well.
The
So all
entire RC was stented, sir, till PLV. That part which appeared to be not stented, sir. Actually, this is covered with stent, but dye was not cleared, sir. Cleared. That's why it is showing that non-stented part.
okay.
So I had shown the video, sir. You can see the video, and it is there. Stent struts are there, sir, throughout there.
Right,
So I used, sir, this feature, sir, of this thing, sir, stent boost feature, sir, for
right.
covering the stents properly.
No, I'm so giving you full compliments to this for doing it quite well in the end. We usually in our day-to-day practice, we get stuck with such complications quite frequently, but all thing which matters for an interventional cardiologist, it is to have solutions to this and come out winning out of all these complications. That is the real test for a very good interventionist.
Yes, sir.
And you have done it quite well. So,
Thank you, sir.